Chapter 18, Sandra Monk, Family Development and Family Nursing Assessment. It's very important to think about the family in the community setting. Families are the context in which healthcare decisions are made. That's a real important concept in both home health, hospice, any type of community nursing, health department, public health settings, even med-surg, pediatric, psych. It's an important concept. And family nursing is practiced in all of these settings also. There's a strong theoretical base, and it's not just common sense, and we'll talk about some of the theories related to this. And the first one that we'll talk about is patient and family-centered care. And this is where we set it up so that the family gives us input, and the relationship is based on dignity and respect for the patient and family and what their choices and decisions will be. Some other theories and other types of assessments that we might do in community health. The community health nurse always builds the plan of care on the family's strengths and resilience. So that's an important concept. Friedman's family assessment is based on strengths and weaknesses of the family. We want to build on the strengths, but it's important also to know what the weaknesses are so that we can help provide, recommend resources and supports in those areas of weakness. Family systems theory views the family as a whole with boundaries affected by the environment. And then the Nightingale theory of environment, as you may remember from earlier in the semester, is where the environment is very influential in the recovery and in wellness of the client, and that's also true of the family. Orum's self-care theory is the individual action is guided by the healthcare provider. The family and the patient are empowered for to be responsible for their own health care, but this is directed and facilitated by the nurse and other members of the healthcare team. And there's an environmental assessment that needs to be done in regard to that, and you do that a lot with home health, with hospice, with public health, but also even in hospital admissions. We talk about what the home environment is like, ask some questions, and particularly if we're discharging somebody home from the hospital, we might do that, and we do that when we first go into the home setting as well. And then the Pender Health Promotion Model is seeking health promotion, which means that the family member, the family, the client, the community must recognize that they have a health problem before they will seek help for that particular health problem. The initial visit of the community health nurse, what we are there for is to assess. The most important first task is to gather all the information needed for the plan of care with the family, and it has to be developed based on what the family is able and willing to do. So the question is, can the care be provided in the context of the family resources and strengths? Because it does no good to really set up this elaborate plan if there are not going to be adequate caregivers, if there's not going to be an adequate environment and supports that are needed to maintain the plan of care. The first visit will be based on the purpose or the reason of the visit in the initial interview. So we know why we're going over there. We know why we're going into the home. We know why we're going into the community to do what our plan is. But then we assess, and then that will be what we will base our plan on, the assessment that we did and the information that we gathered. A genogram is a pictorial representation of multiple generations of the family, and you have one to print out and to complete for your own family to bring to class on Monday. It's very similar to a family tree, and it provides information about medical history and relationships within the family. So you need to know those purposes. And also one of the questions in your weekly discussion is about that as well. Genogram uses are to plan and evaluate effective nursing interventions in a family, because we know what, kind of what we're looking at as far as healthcare problems, looking and to help determine medical and social conditions that might impact the family, and also maybe to anticipate life expectancies of family members and to kind of look for certain disease processes, chronic disease processes, mortality and comorbidities, morbidity and mortality, and then comorbidities. And it would not be used to determine community resources. We're going to use something else. We're going to use an echo map for that. Our echo map pictorially used to depict the family connections to people within the community, and we help that family by identifying um, we identify the family. We find out who the family considers as its members and who will be included in that health plan. Who are the family social supports, for example? Is it someone at church? Will it be neighbors, extended family members? Can someone take a family leave? Is somebody already living in the home or somebody who's able to provide the care? And it illustrates also, you'll see, you have one of these to print out also, and you'll see the hashtags and the symbols and so forth where you can indicate strengths, weaknesses, and the quality of the relationships. The Family Medical Leave Act provides family support through legislation that allows for family members to take a defined amount of time of leave for family events such as births and deaths without a fear of losing their job. And this, of course, there are some, qualifications for this. There must be a doctor's order that says that the family member is ill and someone needs to take care of them, and they are actually disabled. It is for larger companies, say over 50 employees, and an employee usually has to be employed for a certain period of time, about a year before they qualify for this, and also it is time limited. It's not an ongoing or a permanent situation. Of course, it's temporary because they're wanting to go back to their job. Okay, and so that's it for chapter 18. Chapter 19 is family health risks. The focus is on family risks and promoting the health of the individuals as well as the health of the community, because the health of individuals impacts that of families, which impacts that of the community. And knowledge of the family structure and functioning is fundamental to implementing the nursing process to families in the community. And whenever you go out, if you've been out with home health nurses, hospice nurses, you know the type of assessment that they do, and they follow the nursing process, beginning with assessment. When you do your community assessment, you will do the same thing. It's so much like the nursing process in community, more than as much as in med-surg, only you're talking about sometimes you're assessing a community instead of just an individual. Nurses need to go above and beyond the individual and family in order to understand the complex environment of family and how that family functions in order to be effective in reducing family health needs. Major family health risks and nursing interventions, they could be biological or they could be age-related risks. For example, they could be genetic risks. You would definitely find this out if you were to do a genogram, and you begin to see that there are some diseases that may be hereditary and have some type of genetic component. There may be environmental risks. It may be something just within that family related to alcohol and drug use. It could be something related to air quality or quality of the home that the person lives in. And then behavioral risks such as lifestyle type risks, because you would find this out through a health risk assessment. For example, a occupational health nurse or one of the health coaches that works for the insurance companies now will ask the patient and family questions about their lifestyle, about how they eat, about how they exercise, about how they get routine health care, do they know how to access health care, and those sort of things. So a family health risk appraisal is very important in being able to assess that information. Community resources and nursing skills begins with sharing information with families, which means that the community nurse needs to be knowledgeable about what resources and about teaching the material to the patients and the families. They might rehearse with families what questions to ask when they go for their checkups, or whenever they call into the office or somebody calls to check on them. They need to know what kind of questions to ask. We might, as nurses, give them prepared required materials related to wellness, related to their disease process, related to behavioral risks or environmental risks. And we are often the one who is making that initial contact. Nurses are very commonly used as case managers. That is the job that is dedicated to them in the law related to home health, federal law related to home health and hospice, that the nurse is the manager of care. And then and they might help arrange transportation. It's very difficult for a person who has chronic illness or who has debility to be able to get around and get to the to health care. We might help them to identify certain community resources, even financial resources, and so a nurse in the community becomes very familiar with these sort of things. And then we advocate for families to learn how to use these resources. We want to get them to where they need to be. The benefit of a health promotion program: a healthier lifestyle is easier to maintain when helpful patterns of behavior are learned early in life. So you'll see a lot of your health promotion programs focused towards children. And it's not just because children are easy to work with or it's an easy target. It's because learning healthy lifestyles, behaviors at a young age yields a more benefit earlier in life, and lead actually to a longer life, but more quality of life as well. And some examples might be healthy weight and exercise approached as a family program. We know from the literature that this is very well supported, that if a child is struggling with an unhealthy weight or lack of exercise, if the entire family is included, then they're more likely to be successful and have successful outcomes. Tobacco prevention and cessation. I put this one in here because I wanted to remind you again about primary, secondary, and tertiary prevention, because it's something you'll talk about, something likely to be on boards, and something that definitely will be on ATI. The Red Ribbon Awareness Campaign. So this is directed towards smoking in the community. So the Red Ribbon Awareness Campaign is directed towards children. It is a primary prevention program. It's where people go into the schools and talk to children about never starting smoking, not even stopping, but never starting smoking, drinking alcohol, or taking illegal drugs. Secondary prevention might be motivational interviewing of current smokers for the desire to quit by the occupational health nurse. Every year when the employee goes for their annual checkup or their annual health evaluation, then the occupational health nurse would ask them if they're smoking or if they're still smoking, have they taken up smoking, and then begin to talk to them about things to kind of find out where they're at with wanting to quit, because if a person's not ready, they're definitely not going to. So this is part of your secondary prevention. Smoking cessation classes and the administration of nicotine patches, say dispensed by the health department in some cases, can be tertiary prevention. Health risks. The factors that determine or influence whether a disease or you will have an unhealthy result that will occur are called health risks. And the major categories of risk include inherited biological risks. They could be social and physical risks. It's like violence in the community, or environmental risks, living in older homes with lead in the homes, or living in substandard housing without, adequate water, heat and lights and those sort of things, or it could be behavioral risks. So try and think about some of your own risks, because that'll help you kind of remember what health risks are. And the community health nurse needs to be specific. Now, when we're teaching in the community about healthcare risks, so think about this in relation to those risks that you've come up with, so if I want somebody to exercise more, I have to be real specific. If I just say, well, I think you need to exercise more, it would not be near as effective as if I came up with a goal that is measurable and specific, where I say you need to walk 30 minutes a day, 5 days a week, which is a lot more specific. So be real specific with your teaching, and that will better decrease health risks. Personal safety and risks for the nurse. So if you're ever in doubt about your personal safety in the community, you want to leave the area immediately. Get in your car, drive away, then you call the family and you tell them the reason. Now, some of those reasons might be you get out and you see people fighting in the street, or you hear a gunshot, or they have a big dog they didn't put up that you're scared about, and then report it to your immediate supervisor. But you do not have to put yourself in harm's way in order to go see patients in the community. Do not not leave valuables in plain sight in your car, because this is an invitation to someone who may or may not be thinking about breaking into your car. Do not pick up or deliver medications for patients. I know you've probably seen nurses do that. It is not a recommended practice, because nurses can, someone could, know the nurse is doing that, and they could, try to take the medicines from them, and it could be a very unpleasant situation. If a patient will not let you in, sometimes they'll send a kid to the door. Sometimes they're at home, you hear them in there, you smell the bacon frying. So you leave your card with the information and you leave the home. We are not, when you're in the community, with the exception of people like the health department who have, mandated police power for people with TB and situations like that. But if it's a regular home health visit, or if it's a regular hospice visit, we would probably end up discharging the patient if we could not get access to them. But we don't force ourselves to go see them. So we just let them know, and we certainly want to go and see them. And then you would notify your supervisor. Home health visits reduce risks, and this is just ever since it came into place. I mean, home health was in place back, in the New York City, tenements back in the turn of the century, and it was successful then, and it is still successful. And home visits give a more accurate assessment than visits with patients in a clinical setting where they come to you. And the purpose is, you need to know your purpose, why you're going to the home or why you're going to the setting before you go. And there are advantages and disadvantages. So the advantages are you are more likely to be able to see if the patient is, being successful with their clinical regimen, if they have the appropriate care that they need at home, and the patient doesn't have to get out and go somewhere, so you don't have the transportation problem. So there's a lot of advantages. The disadvantages are someone has to get in a car, someone has to schedule this patient, get in a car, they have to go there, there's billing for it, and it has to be all that has to be taken care of. So those can be the disadvantages, and you don't have all your other healthcare team right there with you. So there are disadvantages to visits in the home. To make it more successful, we talk about the different phases of the visit. So the initiation phase, you've got to have an order before you go out into the community to see a patient. You've got to have a physician's order for that if you are going to get, if you're going to be able to get billed and pay for that. And then the pre-visit phase, you want to know why you're going over there, and you want to take the correct items with you. And we'll do some more of this in the sim lab. But if you're going out to draw labs, if you're going out to access a PIC or a port, or you're going out to do a dressing change or a colostomy change, then you need to a dressing colostomy appliance change or something like that. You need to have the correct equipment with you when you go, before you leave, because you may be 40 miles from the office. You need to, in the in-home phase, you want to, make sure that you introduce yourself, that you tell them why you're there, what you're going to do, and you help establish, what is going to happen during that visit. And then the termination phase, actually you begin in that in-home phase when you're telling them that I'm only going to be here for 3 visits, and then after that we will discharge you if you do not need any other services, because we're only there to provide these skilled services. Or with hospice, we don't have that discharge, but we might, because patients can be discharged from hospice if they improve. And so then we would have to provide some type of other care for them and have to have a discharge plan before we discharge them. And then the post-visit phase is we have to do our documentation. That is a requirement for payment, but also for continuity of care, and it's also a legal requirement that we do that. The home visit, the first thing you have to do is establish rapport with the family. That's the first step, within the home visit. You're doing the assessment, but you've got to establish rapport. And without this one, the other ones are very unlikely to be successful until you develop some amount of trust, and they are going to allow you into the home. It includes the nurse's self-identification and clarification of the role, that I'm here for, and I'm here just temporarily. I will just be here for an hour each week, or I'll be here an hour 3 times a week, whatever that might be. And you also want to determine what the client's expectations are. They may think that you're there and somebody's going to stay and be there 24 hours a day, and they can leave while you're there and go somewhere the caregiver can, which is not really good, because you can't really get your complete complete assessment done. I mean, sometimes it works, but sometimes that's, not really a good idea. So you need to find out what that client's expectation is of the home visit. And that's the end of my presentation. Thank you.